We are live.
Very good evening, all. I am Dr. Piyush Bansal, Chairman of the Scientific Committee of Maharashtra Ophthalmic Society, and I take immense pleasure and pride to welcome you all to the inaugural session of Mos Pep, which is essentially our postgraduate education program. Now, it's only befitting that we've named it Mos Pep because it was on the lines of the first and the only postgraduate education program that I had attended called IPEP, which was a brainchild of our esteemed speaker today, Dr. Santosh Unawar, sir. So we have a fantastic program in light of the Retinoblastoma Awareness Week, where we'll be deliberating about retinoblastoma, and we have a esteemed panel of we have two excellent coordinators from Maharashtra, members of the scientific committee, Dr. Sumit Lahane and Dr. Shubha Zawar. We have Dr. Mritika Sen, who's a consultant at Sankar Nethralaya. We have Dr. Seema Das, who's a consultant at Shroff Eye Hospital in Delhi. And we have our own Dr. Aditi Watve, who's a consultant at Astradhar Hospital in Kolhapur. Now, before we go on to the talk itself, I would want to introduce formally our speaker today, who absolutely needs no introduction anywhere in the civilized world. I'm just going to screen share. So, like I said, nobody needs any introduction to Dr. Santosh Unawar, but I will still go through some of the salient features that Sir really means to us. He received his surgical residency training in ophthalmology, followed by his senior residency in ophthalmology at the RP Center in AIMS, New Delhi. He was trained in ocular oncology and was mentored by Professor Jerry Shields and Professor Carol Shields at the Wills Eye Hospital, Philadelphia in USA. Then now, mind you, this is in the 90s. This is at a time where ocular oncology or even oculoplasty was really a budding subject in our country. And he then came back to India and established the ocular oncology service at L.V. Prasad Eye Institute in Hyderabad. Now, I don't know how many lives he has touched and continues to touch in his endeavors. As the Associate Director of L.V. Prasad Eye Institute, he headed patient care services and established the residency program there. He currently heads the Department of Ophthalmic Plastic Surgery and Ocular Oncology at the Center for Sight in Hyderabad. The iFocus PG education program, which is run by him, is extremely popular. And the moment you go on YouTube, you just spellbound with the number of views that it has and the number of people who access it. Now, as an editor of the Indian Journal of Ophthalmology, he was responsible for the impact factor soaring from 0.83 to an unheard of 3.1. And essentially, this was a very proud moment for all of us. He is currently the Honorary General Secretary of the All India Ophthalmological Society. Now, with ocular oncology as his research focus and with over 400 index publications, we're very proud that he tops the Stanford list of researchers of the highest impact in India. Now, something that each line is giving me goosebumps. Some of the major awards and honors to his credit include the Colonel Rangachari Gold Medal by the AIOS. Now, mind you, he was the youngest recipient while he was still a resident. Dr. Siva Reddy International Award by the AIOS. An extremely big honor of Shanti Soru Bhatnagar Award by the Government of India. The Jerry Shields International Award by Asia Pacific Academy of Ophthalmology. He's also received the Lifetime Achievement Award by the American Academy of Ophthalmology and the highest award of the Royal College of Ophthalmologists in the United Kingdom. It's honorary fellowship, both for the first time for an Indian ophthalmologist. Now, there is so many more achievements that that we can add to this, but we've just kept it to a bare minimum. So with this introduction, I would like to invite Dr. Shirish Thorat sir also to welcome Dr. Santosh Unawar sir to deliver his presentation.
Thank you, Piyush bhai. Good evening, all. On behalf of MOS, I welcome you all to this masterclass on retinoblastoma by none other than our own Santosh Unawar sir. As Dr. Piyush said, sir has taken this particular specialty to a different level from India to abroad. We are really honored to have you here, sir. So I thank you all the panelists for spending their valuable time. Thank you, our scientific committee team and all the attendees for making these a series of important sessions and looking forward to great session today also. Over
Thank
to you, Piyush.
thank you so much. Thank you, Piyush, for your kind introduction. Very elaborate. Share my slides. Visible?
Yes, sir.
Yes.
Okay. Retinoblastoma has evolved as a entity because in no other malignancy we have this kind of a turnaround. We had about 98% mortality in 1900s. In 2025, we have a more than 98% survival in the best of centers, which is a total turnaround, and that really hasn't happened in any other malignancy except retinoblastoma. Talk about CA lung, CA breast, we have never had such a good change in the outcome. Now, the clinical manifestations of retinoblastoma are very stark. Leukocoria, in fact, a child comes to you begging for a diagnosis. It's so obvious not to miss leukocoria in a child with retinoblastoma, but it is often missed. It's the most common symptom as well as sign. Pediatricians can notice it, ophthalmologists can notice it, but this goes unnoticed in many situations. Unilateral or bilateral strabismus in 25% of children, which means that every child who comes to an ophthalmologist with strabismus should have a fundus evaluation. Otherwise, your diagnosis or evaluation is incomplete. Reduction of vision is a uncommon sign unless the retinoblastoma is bilateral, where the child may have poor response to vision, but visual stimuli, but otherwise reduced vision is a sign of retinoblastoma in older children who can actually complain that they're not able to see much. If it's unilateral retinoblastoma, often this goes unnoticed. Redness is rare. That indicates that the child has either a neovascular glaucoma, secondary glaucoma, or inflammation in the eye because of tumor necrosis or extraocular extension. This obviously is a sign of extraocular extension or orbital retinoblastoma, and fungating mass is fortunately rare. We also should know about the masquerades of retinoblastoma. Any child who presents with orbital cellulitis, which may look like preseptal cellulitis or even orbital cellulitis, the evaluation is incomplete unless we have at least done an ultrasound B scan. If the lid cannot be opened and you cannot see the fundus, at least an ultrasound B scan, if not a CT scan or an MRI, is mandatory, because many of these children have sterile inflammation of the orbit because of a necrotic tumor. Any white eye with hypopyon. This was a 5-year-old child who had hypopyon, which was being treated by the UVA clinic. But what is very clear here is that there is no circumciliary congestion at all. In such a situation, it is mandatory to do an examination under anesthesia and look at the retinal periphery, because this is diffuse infiltrative retinoblastoma, where you don't find the familiar vitreous or a retinal mass, but the tumor will be right at the periphery of the retina, and that infiltrates the trabecular meshwork, iris, and finally comes into the anterior chamber as this hypopyon or pseudohypopyon. Congenital glaucoma can also be retinoblastoma can also manifest like similar to congenital glaucoma with buophthalmus and enlarged corneal diameter. If this child were to have more of corneal edema and this hazy yellow reflex that is peeping through was not visible, then you could have treated it as a case of buophthalmus. So in a child with buophthalmus, if you cannot see the fundus, it's mandatory to do an imaging before you perform any glaucoma surgery. Thysis bulbi can also be a manifestation of retinoblastoma. Children with minor trauma can be attributed to have thysis because of trauma, but actually it's the sterile inflammation that induces ciliary body shutdown, and these eyes get into thysis. And when you do CT scan as a screening modality in these patients, you find intraocular calcification, where you find the tumor right in the vitreous cavity, and the calcification is right in the vitreous cavity. Whereas if there is dystrophic calcification, that would be in the coats of the eye. So that's how you differentiate a dystrophic calcification in a thysical eye or an atrophic eye from intraocular calcification because of retinoblastoma. So you should never enucleate a thysical eye unless you've done imaging, because often these eyes may have optic nerve extension, and because of the enophthalmus, you don't even clinically think of an optic nerve extension. But while doing enucleation, you might find a long optic nerve extension. So you have to do imaging, especially MRI is mandatory in patients who have had a thicycle eye because of retinoblastoma. Hyphema can also be a manifestation of RB. This child comes with a history of injury to her eye. Obviously, there is a small lid laceration, but this full chamber hypopyon can be attributed to trauma. That's exactly what was done by the treating ophthalmologist to drain the hyphema and also did a trabeculectomy for the secondary glaucoma that the child had. 6 months later, there is obvious extraocular extension, regional lymph node metastasis, and also intracranial extension of retinoblastoma. Vitreous hemorrhage can also be a manifestation of retinoblastoma, especially in older children with diffuse infiltrative retinoblastoma. So these are all the various masquerades of retinoblastoma, but should note that most commonly the older children have masquerades, and any child with atypical finding, especially an older child, you should suspect retinoblastoma. The diagnosis is very straightforward. All you need to do is a good examination and anesthesia. Ultrasonography B scan helps identify intraocular calcification, and it also helps you measure the height of the tumor and perhaps the diameter of the tumor. CT scan is useful in patients where you want to rule out simulating conditions by looking at intraocular calcification, but CT is relatively contraindicated because of the radiation exposure that it does to children with retinoblastoma, which can induce second malignant neoplasm. But what is important is to do an MRI scan. A baseline MRI scan helps detect some aspects of retinoblastoma which can otherwise go unnoticed, such as this child has no proptosis at all. Eyes are absolutely at the same level, but the child has extensive optic nerve invasion. Whereas if you try to enucleate this eye, obviously, if you're not aware that there is optic nerve extension, you may leave some residual tumor behind. But if you're already aware that there is optic nerve extension, you would chemoradiose this patient with neoadjuvant chemotherapy, then you would do perhaps secondary enucleation. This patient has a small tumor, but you can see that there is a massive choroidal invasion already, which means that intra-arterial chemotherapy is not the right thing because choroidal invasion is a clinical risk factor, and these children have a high risk of systemic metastasis. So either you do an enucleation in this patient, or if you want to try to conserve the eye, give intravenous chemotherapy, which can even take care of microscopic metastasis. Clinically, there are four types of retinoblastoma: endophytic, where the tumor goes into the vitreous cavity; exophytic, where there is exudative retinal detachment; diffuse infiltrative is a placoid kind of a tumor. So if this is the retinal surface, you can find the tumor hugging the eye in a very placoid fashion, where the thickness of the tumor is not more than 20% of the overall diameter. And there's a mixed configuration where there's part of which is endophytic, part of which is exophytic, and part of which is diffuse infiltrative, which is the most common manifestation. Common clinical simulators, top five are Coats disease, PHPV, toxocariasis, astrocytic hamartoma, and medulloepithelioma. Coats disease is very striking. You can not miss Coats disease. If you're a very careful observer, you'll find that children with Coats disease have this golden yellow or yellowish reflex, whereas retinoblastoma has white reflex. So if you have this yellowish golden hue, then that is called xanthochoria, and it is how that's how you clinically suspect that the child may have Coats disease. When you look at them on indirect ophthalmoscopy, you find intra and subretinal exudation extensively, exudative retinal detachment, and peripheral retinal telangiectasia. That's how you differentiate Coats disease from retinoblastoma. You can see the quality of the white reflex. This is golden yellow, whereas this is white. So that is how the difference is very obvious. Yeah, now PHPV. In PHPV, obviously there would be some amount of microphthalmus. Even 1 or 2 millimeter difference in the diameter of the eye is significant. And when you look at them carefully, you find that there are prominent ciliary processes, and obviously that's a retrolental membrane or the posterior polar cataract. So if this is the lens, there would be a fibrovascular front arising from the back of the lens going up to the optic nerve, and that is a telltale sign of PHPV. And in toxocariasis, if it's a peripheral toxocara granuloma, you find this desmoplastic element, tractional fold, or a falciform fold, whereas in retinoblastoma, you don't find it. Whereas if it's a posterior polar granuloma, you find the dragged disc appearance where the vasculature seems to be dragged towards the granuloma, whereas in retinoblastoma, you don't find such an appearance. Whereas retinal astrocytic hamartoma is like a button placed on the retina, kind of an appearance, which kind of masks the underlying vascular architecture of the retina. It could also be calcified, where the calcification is like fish egg calcification, discrete globules of calcification, all clumped together, and that's how it appears on indirect ophthalmoscopy. Medulloepitheloma is a peripheral ciliary body tumor. It's an embryonic tumor. So the zonules in the quadrant or the clock hours where the tumor is present are missing. That's called zonular coloboma or lenticular coloboma. And the ciliary body tumor is quite evident. So those were the differential diagnosis. Going on to classification, we have two ways of classifying any tumor: staging, where survival is the outcome, and grouping, where the organ or the eye salvage is the outcome. For staging, we have the international staging system. Stage 0 is when the eye has been conservatively managed, no enucleation has been performed. Stage 1 is when enucleation has been performed and the tumor is completely resected. The key word is complete resection, which means that histopathologically you have confirmed that there is no optic nerve transaction involvement, full thickness scleral involvement, or extraocular extension. So histopathology becomes very important when you want to stage these children, because staging has prognosis in terms of life salvage. Stage 2 is when enucleation has been performed with microscopic residual tumor, which means that the child will need adjuvant treatment from stage 2 onwards. Stage 3 is when there is orbital extension or lymph node metastasis. Up to stage 3, there is 90 to 95% survival. Beyond stage 3, there is less than 5% survival. So this is the kind of a watershed zone. So you should try to pick up children before they reach stage 4, where systemic hematogenous or CNS extension would be nearly lethal. International grouping of intraocular retinoblastoma is a very simple classification where group A are smaller tumors less than 3 millimeter in diameter. Group B are bigger, that means more than 3 millimeter in diameter. Macular tumors closer to the fovea, closer to the optic nerve, and with subretinal fluid. So group B has many attributes: tumor larger than 3 millimeter, macular tumor closer to the optic nerve, less than 3 millimeter from the fovea, less than 1.5 millimeter from the optic nerve, and with subretinal fluid. So all these attributes make it group B. Group C are tumors with focal subretinal seeds if it's an exophytic tumor, or focal vitreous seeds if it's an endophytic tumor. Now, group D retinoblastoma is with diffuse subretinal seeds or diffuse vitreous seeds, and group E are potentially enucleable where there is neovascular glaucoma or hyphema or vitreous hemorrhage. Now, about TNM classification, which is the latest form of classification of retinoblastoma. TNM is tumor node metastasis. The alphabet H has been added now, especially for retinoblastoma, which indicates heritability. So heritable trait has been added to TNM group, which now brings in genetics as one of the major factors in determining screening for children with retinoblastoma, and also sometimes having a bearing on the prognosis. Coming to the management of intraocular retinoblastoma, the goals are to be very clear. Primary goal is life salvage. Secondary goal is organ salvage or the eye salvage. And the tertiary goal is optimal residual vision or salvage of vision. When you have these goals all clear, then it's easy to manage retinoblastoma. You should never reverse the goal. When you have a very small tumor, say 3 or 4 millimeter in diameter, 2 to 3 millimeter in thickness, life is never at stake. Eye is never at stake. So what you try here is to optimize vision. So for small tumors where there is no life risk or risk for eye salvage, you optimize vision by using visually conserving measures, which could be cryotherapy perhaps for a peripherally located tumor. Peripheral tumors don't have a direct bearing on vision. That's why you can use cryotherapy. Although the scar that is produced is going to be much larger than the tumor that you begin with, because cryo is very heavy You center the tumor on tip of a cryoprobe, which is 3 to 4 millimeter, and then indent the tumor and cryo until the vitreous cuff of vitreous, which is anterior to the tumor, is included in the ice ball. So it's a very heavy cryotherapy, thus resulting in a much larger scar, which is okay on the nasal periphery. But if you have a tumor which is, say, anterior to the equator, you can reach with a cutting cryo, as they used to call. You do a peritomy and then reach with a long armed cryoprobe. But that is going to be visually morbid because you're going to induce changes in the macula. You can have a epiretinal membrane. You can also, by repeated cryotherapy, induce atrophic retinal breaks causing rhegmatogenous retinal detachment. So cryo is good, but not the best. Laser photocoagulation. Still, many centers use laser photocoagulation where the principle is to cut off the blood supply to the tumor. This is called anemization. By using large diameter laser burns in two confluent rows around the tumor, you're going to reduce or cut off its blood supply, which is good. But what happens to the scar? Scar is going to be much larger than the tumor that you begin with. And more importantly, there is vascular occlusion in the area where you are done laser photocoagulation. And that apart, these children, if they have a juxtapapillary tumor which is close to the optic nerve, obviously they can cause a visual field defect which is very large. They can have a central visual field defect if you do this kind of heavy laser in a posterior polar tumor. And if you were to inadvertently do laser on top of a tumor, then you can induce vitreous seeds as well. So alternative would be transpupillary focal therapy, transpupillary thermotherapy. Now, if somebody asks you what is the ideal treatment for focal treatment in a child with retinoblastoma, the answer would be transpupillary thermotherapy. This is a way of doing laser, but then not photocoagulation. This would be to gently heat the tumor to about 65 degrees centigrade by using semiconductor diode laser. This is done right on top of the tumor, not around it. So scar is not going to be larger than the tumor that you begin with, and also the blood vessels that pass through the tumor are not going to be affected. So this is least visually morbid in terms of focal therapeutic measures. Now, the recent advance in focal therapy is using ICG, indocyanine green, which is a common dye available. Simply inject indocyanine green. It works in synergy with the wavelength of semiconductor diode laser. So you kind of have a much pronounced effect on the tumor when you inject ICG, specifically in on tumors which are lying on a amelanotic scar. This is a child where there was a regressed scar, there is chorioretinal atrophy, and on top of that, there is a recurrence, and that could be treated with indocyanine green enhanced transpupillary thermotherapy. Plaque brachytherapy is extremely good in terms of success, but can produce a large scar. Plaque is still used where chemotherapy is relatively contraindicated, like in this child with thalassemia major, but also in patients who have a recurrent tumor, plaque can be used. Plaque is generally not considered as a primary therapeutic measure. It is used in patients who have a recurrence following primary management with some other modality, or for refractory tumors which don't respond to the primary management modality. Now, about chemotherapy, chemotherapy was introduced in the management of retinoblastoma in 1997, and that was intravenous standard chemotherapy with three drugs: carboplatin, vincristine, and etoposide. Now, what came along later was all these new forms of chemotherapy, which I'll be describing one by one. Intravenous chemotherapy has several advantages. It uses three drugs, as I said, 3 to 4 weekly cycles, and at least 6 cycles of intravenous chemotherapy is given. Once committed, you have to give 6 cycles of intravenous chemotherapy. The first effect is by reducing the size of the tumor itself. So large tumors of this sort become much smaller scars. So reduction in size is beneficial because macular fovea get exposed early in the course of treatment, thus maximizing vision. The second effect of chemotherapy is that the tumor always regresses towards its source of blood supply. Note that this patient at the initial manifestation has tumor impinging on the fovea macula, correct? And the supratemporal arcade is the blood supply. The tumor, after one cycle, has left the fovea and has gone regressed away from it. After 3 cycles, you can see that the tumor is almost flat and it has moved totally away from the fovea macula. So you can see nice macula and foveal reflexia, and the tumor has regressed away from its towards its source of blood supply, away from the foveal macula, thus maximizing vision. So that's the second effect of intravenous chemotherapy or even intraarterial chemotherapy, any form of chemotherapy. One more example of a tumor which was impinging on the macula, and you can see after 6 cycles, macula absolutely clear and the fovea absolutely clear. The third effect of chemotherapy of any form is that the excretive retinal detachment settles very quickly in the course of treatment, thus again maximizing vision. With these three advantages, shrinking of the tumor, regression of the tumor towards its source of vascularity, especially useful in posterior polar tumor, and exudative RD settling down, you have much better chance of gaining vision. Intravenous chemotherapy is still used in India predominantly or in countries where there is uh, concerns about the cost of care. Intravenous chemotherapy is relatively inexpensive. It can be given in ophthalmic settings, of course, with the help of an oncologist, but the cost is very, very affordable. Whereas intraarterial chemotherapy, although we have the technology to deliver super selective ophthalmic artery arterial chemotherapy, we do it routinely. Our interventional radiologists have an excellent cannulation rate. There are minimal complications. It is expensive. Here we use a 400 micron catheter to get into the ostium of the ophthalmic artery, simply peep into it and deliver 1 to 3 drugs. If somebody asks you what is the drug of choice, that is melphalan. Melphalan is the gold standard for intra-arterial chemotherapy in retinoblastoma. You can use topotecan, you can use carboplatin. There are attempts to use only one drug, that is topotecan, but the results are suboptimal. When you use melphalan, it's very powerful, and the results of intraarterial chemotherapy are excellent. You can use drugs to reduce the number of cycles. This is obviously a group C retinoblastoma. There were focal subretinal seeds, and you can see nice results after 3 cycles of intraarterial chemotherapy. Tumor is almost flat, and the residual obviously has to be taken care of by transpupillary thermotherapy. Larger tumor, with vitreous seeds calcified, and the tumor nearly totally regressed after 3 cycles of intraarterial chemotherapy. Much larger tumor with diffuse vitreous seeds, you can see how small the tumor has become, healthy optic nerve and macula, good visual possibility. Retinal detachment settled and the tumor regressed. Total retinal detachment settled and the tumor regressed. Again, a total bullous retinal detachment settled and the tumor regressed. So intraarterial chemotherapy works like magic. Of course, never 100% success, but it has much better success than intravenous chemotherapy, specifically in group D and E retinoblastoma. Whereas in group D, it gives about 10 to 15% higher chance of eye salvage. In group E, also it gives almost 10 to 15% higher chance of eye salvage as compared to intravenous chemotherapy. So you have more eyes saved with intraarterial chemotherapy than with intravenous chemotherapy, especially in advanced retinoblastoma. Coming to the vitreous seeds, as we knew them, no longer exist, which means that the classification has changed. We have a new classification proposed by Munir. We further subclassify vitreous seeds into prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds. And we also have a new classification for intracameral seeds, which is depository and infiltrative. Now, why should we differentiate depository from infiltrative? Mainly because depository seeds are not high-risk features. They're simply vitreous seeds which have come through the zonules and settled in the anterior chamber. They don't have a higher chance of mortality. So you can treat intracameral seeds as long as they're a depository by conservative measures and try to save the eye. It is not a crime. Whereas if the seeds are infiltrative, where the pupil is distorted, it is D-shaped pupil, you can see iris infiltration, then that is a clinical high risk factor. These children can be enucleated. Enucleation is preferred in these children, although some of these eyes can still be saved. Morphological classification of vitreous seeds, we have dust, as the name indicates, cloud, as the name indicates. Again, these are morphological classifications. Sphere, again, as the name indicates, and the mixed pattern. So we have new classification for intraocular seeds, and specifically for vitreous seeds, we have a morphological classification. But how do we manage these seeds? When there is a viable retinal tumor, then obviously chemotherapy of some form has to be given, intravenous or intraarterial. And to augment the effect, we give periocular chemotherapy, which is topotecan. So when the child is on intravenous chemotherapy, intravitreal concentration of chemotherapy is not going to be high, so we augment it by periocular chemotherapy. Even with intraarterial chemotherapy, if melphalan is given intraarterially, then you can augment it with periocular topotecan. But when the retinal tumor has nearly totally regressed and there are viable residual vitreous seeds left, then we give intravitreal chemotherapy. Intravitreal chemotherapy has really enhanced the chance of eye salvage in the presence of intraocular seeds. So the criteria for safety enhancement. So what exactly is safety enhancement? Which means that these are the measures that are taken to reduce the chance of extraocular extension of retinoblastoma by the process of giving intravitreal chemotherapy. So perforating an eye with retinoblastoma is not something that was considered safe earlier. Now it is considered safe as long as you follow these measures. That means that the viable retinal tumor should not be large. Use a safe site which is at least 3 clock hours, ideally diametrically opposite from the location of the major component of vitreous seeds, but at least 3 clock hours from a clump of evident vitreous seeds. Exit through eyes, which means that if you have injected using obviously a needle, you have to apply cryoprobe on the sclera, episclera, conjunctiva. Let the ice ball form, which should incorporate the hub of the needle. Then withdraw the needle through this ice ball. So that's called exit through eyes. Then on top of that, you perform injection site cryotherapy, triple freeze thaw. Death by water is a technique where you pull in distilled water in the cul-de-sac and hope that these cells, if at all they have come out of the eye, or get autolyzed. Bleb of subconjunctival topotecan is also one of the possibilities. With all these measures incorporated, the chance of extraocular extension is extremely rare. This is a child with focal vitreous seeds, I would call, with melphalan. You can see nice results. So this was my first case. After that, we started injecting melphalan liberally, and we found certain complications which are not very predominantly described earlier, especially in Caucasian eyes. These are not seen commonly at all. Those were RPE atrophy. Extensive retinal pigment epithelial atrophy was seen, sometimes affecting vision. In addition, we started seeing uveitis, bound on pupils. We started seeing cataracts. And also the fact that melphalan needed weekly injections. It's very difficult to get these children in every week under anesthesia and inject them. They needed multiple injections, thus increasing the risk of maybe an endophthalmitis. And they also have known toxicity on the retina. So topotecan has replaced melphalan currently, especially in pigmented places such as ours, because of its better bioavailability, lack of these complications, fewer injections, 3 to 4 weekly injections, and apparent lack of retinal toxicity. This was a study which was written by Ritika, uh, where we have documented the long-term efficacy of intravitreal topotecan in vitreous seeds. This was a large series of 90 plus eyes. Intravitreal topotecan, initially we started using 30 microgram as a safe dose, 3 to 4 weekly, and we found very good results in focal seeding. All these patients with focal or limited diffuse seeding resolved with 2 to 3 injections of intravitreal topotecan. Very good results, excellent outcome in terms of absence of retinal toxicity and complications. But when the vitreous seeds are very extensive, then you can use a higher dose of topotecan. That's the current concept, 60 or even 90 micrograms. 90 microgram we use for diffuse vitreous seeds and also for patients with endophytic retinal tumors and extensive subretinal seeds. There's a case for tandem therapy with topotecan and melphalan. This is a patient where there's a retinal tumor and a bunch of vitreous seeds. This is the primary manifestation. After chemotherapy, retinal tumor has regressed, and what is left are a bunch of vitreous seeds. Now, after starting topotecan after 6 cycles, vitreous seeds are obviously less than what was seen before. but they are still present. So at this point in time, we started adding low dose melphalan and the seeds went away, but what followed is retinal pigment epithelial atrophy. So melphalan and topotecan can be used in combination. For anterior chamber seeds, you can use either intravitreal chemotherapy or intracameral topotecan, both of which work very well. For infiltrative anterior chamber seeds, you can do brachytherapy for the ciliary body component, iris component, and intracameral chemotherapy for the anterior chamber seeds. For extensive subretinal seeds, we can do intravitreal topotecan, again with good results. There is no need to do transpupillary thermotherapy or laser. Coming to enucleation, if someone asks you what are the indications for enucleation, you should say bad group E. Now, what is bad group E? How do you define it? There's no clear definition, but whenever there are clinical risk factors such as neovascular glaucoma, secondary glaucoma, neovascularization of the iris, anterior segment infiltration, that means infiltrative anterior chamber seeds or iris infiltration or ciliary body infiltration, hyphema, vitreous hemorrhage, Buphtalmus or steroid inflammation of the eye with necrotic tumor. These are clear indications for enucleation. There is no controversy at all. And what are the precautions that we need to take during enucleation? It should be a minimal manipulation technique with adequate precautions not to accidentally perforate the eye. Optic nerve stump has to be as long as possible, at least 15 millimeter, if not 20 millimeter. That can avoid getting transaction positivity on histopathology. Primary orbital implant is mandatory because you have to assure certain amount of cosmesis to the children. This is a primary orbital implant and that's following custom ocular prosthesis. You can see that this is almost indistinguishable from a normal eye. Now, for residents, you have to realize how exactly to do enucleation because some of you may be asked to do enucleation as a resident. Enucleation by myoconjunctival technique is very simple. This was a 4-year-old child with unilateral retinoblastoma, where we begin with a small lateral canthotomy. Cantholysis is not required. Then you do 360-degree peritomy as close to the limbus as possible. Blunt-tipped conjunctival scissors is used to do the peritomy. And once you've done the peritomy, you dissect the tenons in oblique meridia between the recti, go beyond the equator, and then hook the extraocular muscle starting from medial rectus, inferior, lateral, and superior. In the order the muscles are inserted from the limbus. Tag the muscles with a tag suture, 40 silk at the insertion, and about 6 to 8 millimeter distally by 60 vicryl. Then you hook the oblique muscles and cauterize and cut them. You don't have to tag the oblique muscles at all. Once you've disinserted all the 6 muscles, make a small conjunctival relaxing incision on the temporal side, prolapse the eyeball through the blades of the speculum, go between the lateral rectus and the eyeball with a 15-degree curved tenotomy scissors, strum the optic nerve, go to the orbital apex, get the hard stop, then open the scissor, engage the optic nerve, and with one bolt cut, you're supposed to cut the optic nerve. With a long stump, as you see here, that's the vertex vein which is dilated that has to be marked for the pathologist to take section from 20 millimeter optic nerve stump without much effort. The implant silicone or PMMA has to go posterior to the posterior tenons. Posterior tenons has to be securely closed using 6 vicryl sutures, interrupted sutures, and then the myoconjunctival technique would involve suturing the extraocular muscle just close to the respective fornix. This will increase implant motility by many folds, comparable to porous polyethylene implant. This is an important technique which will ensure good dynamic cosmesis. Anterior tenons is also closed with interrupted 60 vicryl sutures, and conjunctiva is closed with a continuous key pattern suture, which makes the conjunctival edges well approximated but everted so that there is no burying of the conjunctival epithelium, thus forming retention cysts. Now, tarsography is important so that the conformer is retained well, and that's how enucleation is performed. The long optic nerve stump, there are many measures which I've already explained how to take a long optic nerve stump during enucleation, and residents should try to practice these measures. Following enucleation, what is important is to look for histopathological risk factors which are present in a majority of children in India who undergo enucleation. Now, what are the histopathological risk factors? Anterior segment infiltration, iris trabecular meshwork infiltration is a risk factor, although a soft risk factor. Ciliary body infiltration is considered a hard risk factor. Choroidal invasion, which is major choroidal invasion, is more than 3 millimeter in thickness, more than 3 millimeter in diameter. Optic nerve invasion beyond the lamina cribrosa is also considered a high risk factor. In all children with high risk factors, we have to give adjuvant therapy. Adjuvant therapy is given in patients who have ciliary body involvement, major choroidal involvement, or optic nerve involvement beyond the lamina cribrosa, or minor choroidal involvement, or with any amount of optic nerve invasion. Additional radiation has to be given for patients who have a optic nerve transection involvement or full thickness scleral or extrascleral extension. So this is called adjuvant therapy following enucleation. There were many studies which had looked at the results of adjuvant therapy, but what changed the protocol was uh, the study when we found that the risk of metastasis would be 24% if you don't give adjuvant therapy, and it can be reduced to minus 4% if you were to give adjuvant therapy, which means that 20% of more children can be salvaged just by the fact that you're looking at the histopathological risk factors and providing adjuvant therapy. This was studied in detail by a multicentric international study by the Children's Oncology Group, which also established the role of adjuvant therapy. This included 331 children studied over 5 years. This was a prospective study, and this has currently established that adjuvant therapy has a role to play. So enucleation is not the end in the clinical management of retinoblastoma. Last part is about the orbital retinoblastoma, the incidence of which varies quite a lot. It could be primary, where the child presents with orbital retinoblastoma. Clinically, as you see here, proptosis, or radiologically when you detect on MRI or CT scan. Secondary is when the child has an orbital recurrence following enucleation, unfortunately. Accidental is when you have perforated an eye with retinoblastoma. You probably have done a vitrectomy thinking that it is endophthalmitis, then it is accidental orbital retinoblastoma. 70% mortality, which is something which is to be worried about. So in these children, we don't do orbital exenteration, but perform multimodal treatment. Multimodal treatment involves sequential combination of chemotherapy, surgery, and radiation. Example, this is an orbital component that gets reduced with neoadjuvant chemotherapy. You can see eye gets into phthisis. Then you do an enucleation with a long optic nerve stump or en bloc excision or an extended enucleation, give stereotactic radiation, give adjuvant therapy. Optic nerve invasion, again, same protocol can be used. Optic nerve caliber becomes normal. Anterior intracranial extension to cavernous sinus, again, the same protocol, it goes away and the residual can be easily treated with stereotactic radiation. Of course, bonus is cosmesis. You don't have to do exenteration. Lids become normal. You can simply enucleate, complete the treatment, and give a customized ocular prosthesis. Even lid infiltration, as you see here, you can see lid becoming nice and flat without the need for orbital exenteration, just the multimodal treatment. Prognosis is quite good in at least in centers where protocol-based management is performed. It almost mimics what is seen in the West, about 95% life salvage. With chemo reduction, where you can treat up to good group E, you have about 80 to 90% eye salvage overall. 95% is the vision salvage in eyes which are saved, and about 50% have vision greater than 20/40. Vision is an attribute of the location of the scar, so you cannot promise vision in every child. If there's a macular scar, obviously there will be no central vision. So in conclusion, to sum up everything, in a child with group A retinoblastoma, focal therapy is the treatment of choice. Focal therapy ideally would be transpupillary thermotherapy, and the latest advance is ICG enhanced transpupillary thermotherapy. Group B, in a visually critical location, macular tumor or a juxtapapillary tumor, for the sake of vision, although you can treat them otherwise with, say, laser thermotherapy, you still use chemotherapy for the sake of vision because you want to reduce the size of the tumor and thereby give back some amount of vision to these children. Group C, D, and good E chemotherapy, either intraarterial or intravenous, work equally well. For D and D, intraarterial is preferred with local and focal therapy. Bad group E or with clinical risk factors, you provide primary enucleation with histopathology-guided adjuvant therapy. Stage 2 retinoblastoma, where there is post-enucleation residual tumor, adjuvant EBRT with chemotherapy. Stage 3, of course, orbital tumor and regional lymph node metastasis, multimodal treatment. And stage 4, where there is already metastasis, then you perhaps give palliative care. These are all cost-effective measures that I described, except the intra-arterial chemotherapy part, and they can easily be practiced in a good retinoblastoma center with multi-specialty collaboration. Thank you so much.
Thank you so much, sir, for this exhaustive talk. I think practically everything has been covered. I'll request Dr. Shubha Zawar, Madam, and Sumit to invite our panel to have a short discussion.
Yeah, wonderful talk, sir. And we've been listening to you over so many years and still learning from you about retinoblastoma. Wonderful talk, sir. So, is Siva here, Dr. Siva? Yeah, so.
Hi, Dr. Shubha, I'm here.
Yeah, hi. So, welcome. Sir has explained wonderfully well the differential diagnosis of retinoblastoma. And basically, I'm happy that he showed the enucleation video, which is very much required for the PGs. And we are still learning from him, as I said. So ICG enhanced TTT was a new thing that I learned from him today. So any comments, Dr. Aditi, you would like to speak?
I would like to just know the criteria for genetic testing. Like, do you do in all cases, whether it depends on the age or laterality, how the patient presents, and how, like, for the benefit of all the ophthalmologists who are basically at slight periphery, how do they actually approach the testing centers, and what is the approximate cost? So that needs to be counseled. So
Ideally you should do genetic testing in every child with retinoblastoma. Especially in a large tumor, you don't know whether it is multicentric or it is a single tumor. You never know whether it's a confluent multifocal tumor, which has become like a single tumor. It is filling the entire eye. So genetic test is ideal. But if you want to really triage, it is unilateral, multifocal or bilateral retinoblastoma. Definitely you have to do genetic testing, not for the child. We already know that the child has a mutation, but for the sake of parents, if they want to have a second child, or it will also help in screening future children. If both the parents don't have a mutation, the newborn can simply be subjected to a genetic test, and if the gene is negative, then perhaps you don't have to screen so rigorously. Although no genetic test is 100% sensitive and specific, you always give that 4-5% leeway. That possibility is always there. Yeah, for the child, it does not benefit in terms of management because we already are treating the tumor and there is no better way to treat than what we have. Prognostication sometimes you can, especially in the presence of some nonsense mutation, missense mutation, prognosis can be gauged, but otherwise it is ideal to do in every child for the sake of the future siblings of the child, not for the child itself. And it is easy now because Arvind offers genetic testing. Of course, there are private organizations, private companies as well. All you need to do is send the blood sample. Yeah, Arvind, I think, is the most affordable. Can Kids offers genetic tests free of charge through Arvind and other collaborations.
thank you, sir.
Uttika, Seema, if any comments or questions for Sir for the benefit of all residents and ophthalmologists tuned in?
Yeah, so just to clarify again for the benefit of everyone who are listening, especially the the residents or maybe the the comprehensive ophthalmologist, because primary enucleation is something which is not really done only by an ocular oncologist or a trained person, but I think it is done by ophthalmologist per se. So what are the kind of tips or maybe the absolute must we should look at before we go ahead with the primary enucleation for any retinoblastoma child?
You're asking me.
Yes.
Okay. Right. Okay. I thought you were going to talk about.
Just some
Now,
important points which
first
are
is
like an absolute must. Yeah.
absolute must is to confirm the eye on the table. Both eyes dilated, child identified, and confirmed on the table is mandatory. Dilatation is mandatory, confirmation by the surgeon, and obviously the surgeon has to stand until the child is draped and then go for scrubbing. You can't identify the eye and go for scrubbing because the other eye may be draped. That all these have happened to various people in the past, and nobody wants that happening. And once you've done that, before you do enucleation, you have to rule out any extraocular extension by doing a good MRI. Now, MRI has become mandatory. If there is optic nerve extension, etc., then enucleation may not be the answer. And you may want to even do a lateral orbitotomy bone cut and go to the orbital apex and get the longest possible stump if there is optic nerve extension. But prior neoadjuvant chemotherapy would help. So you rule out extraocular extension, optic nerve extension, not to do enucleation in a child with inflammation because you may perforate the sclera accidentally, and also there might be more bleed. Then for the peritomy, you have to go as close to the limbus as possible. Always use a blunt tipped conjunctival scissors. And when you hook the extraocular muscles, be careful. Sometimes these sharper muzzle hooks can perforate the eye and sclera, especially if it is a fragile sclera. And when you pass the traction suture, don't pass it very close to the insertion of the muscle. Leave a gap of at least a millimeter or two, because then again, you don't want any perforation, accidental perforation at this stage. Always have a standoff. That means create some space between the muzzle hook and the muscle and pass your suture tangentially rather than we're going very close to the sclera. Those are the precautions. And dissect the tenons in oblique meridia already so that your posterior tenons is well released. Then when you cut the optic nerve, if you have a habit of doing the medial approach, which is perfectly all right, then you should not use a semi-curved scissor. You should use a straight scissor because medial orbital wall is absolutely perpendicular, right? So you have to use a straight scissor to cut the optic nerve, get the longest stump on the medial side. Whereas if you go from the lateral side, since the lateral orbital wall is at 45-degree angle to the medial wall, then you use a 15-degree curved tenotomy scissor. If it is more curved, you get a shorter stump. So 15-degree curved tenotomy scissor would simply snuggle into the orbital apex without losing much of the stump. And secondly, if you use a 15-degree curved tenotomy scissor, you damaging the superior orbital fissure structures if you go from the lateral side is much less. So we see some of the enucleations where there is total ophthalmoplegia. That's because surgeon would have cut right at the superior orbital fissure. In the enthusiasm of cutting a long optic nerve stump, they would go and cut the superior orbital fissure because they would be cutting very close. So when you hit the bone, I always advise that you lift the scissor by a couple of millimeters, then you open the scissor and engage the optic nerve. Like you you kind of, you know, kind of strum the optic nerve, then reach the orbital apex, lift by 2 millimeter and engage the optic nerve and cut. That's how you can save. And also bleeding will be very brisk if you cut the superior orbital fissure structures. So I think that is how. And never use a enucleation scissor or a enucleation spoon. Always use a tenotomy scissor. And don't pull on the optic nerve, pull on the eyeball too much. Simply prolapsing the eyeball through the blades of the speculum would stretch the optic nerve to straight kind of a thing, rather than pulling on too much, because there's an older study where unilateral enucleation was performed with long stump. And when they did visual fields in the other eye, when the child became an adult, they found visual field defects, possibly some amount of traction on the chiasm. So anyway, it's not a good idea to pull on the sutures. Sutures do break sometimes.
Also,
One thing I would like to actually add, like in my area, it's not a part of actual RB management per se, but many of the times when comprehensive ophthalmologists are doing RB enucleation, they somehow do not prefer putting implant. For what reason, I'm not sure. So they just do the enucleation. So that way we are actually losing the chance of putting a good implant in the proper place, because secondary implant is most of the times going to migrate in those children, compromising their cosmetic outcomes and in all, like rest of the socket management. So even if it is not a part of RB management as such, it is a part of overall management of the patient. Sir, what is your experience about it. It's very common in my part, so that is why I wanted to highlight that.
Implant is mandatory. Implant is mandatory.
Absolutely.
Yeah, and you can give radiation on top of a silicone implant. There is no problem if at all is indicated.
Exactly. So what I feel is when your enucleation is done, you're sure that you are kind of removed all the tumor. So why are you not putting the implant inside? And implant is not a contraindication either for chemo or radiation. So it is a
Absolutely.
must,
Yeah.
is what I feel.
Okay, can I have a minute?
Mhm.
So I had this, I saw a patient with this large tumor coming out of the orbit. And then I got to know that he was enucleated and an implant was kept inside. So maybe the pathologist hadn't, examined the earlier enucleation, or I think the kid was eviscerated. So yeah, so it wasn't examined, and then the implant was put, and it resulted into a recurrence of this retinoblastoma.
Evisceration is contraindicated. You should never perform
Yeah, but
evisceration.
general ophthalmologist,
They should not perform evisceration in children because sometimes you don't know what is the reason for this atrophic bulbi in children. If they haven't done a good imaging, there is no reason to perform evisceration in children.
So I feel even such suspicious eviscerated samples also should be sent for.
You should not do evisceration at all in children.
No, but in cases where it has been done, maybe
Yeah.
general ophthalmologist doing it. Another point is never to forget examining the other eye under anesthesia while enucleating this eye.
I think for taking a decision of enucleation, always EUA should be done, which will decide about the stage, laterality, everything. EUA and enucleation, at least in my practice, I do not combine. First
Absolutely.
EUA, talk to the parents, talk about the plan, and then go for enucleation. There is no point in saving one GA. It is fine. Like the GA these days are pretty comfortable and safe. So I feel first EUA followed by the plan is the thing which makes everybody more comfortable and confident about the treatment.
Agree.
Sir, thank you for the wonderful talk again. Just wanted to ask, when we send for MRI, when the child first comes in, what are the specifications that we should mention regarding the MRI?
MRI has to be done with stir sequence, T1, T2, fat suppression, and with contrast. If they don't do contrast, then choroidal invasion is very difficult to comment. With the expert neuroradiologists that we have access to, chance of misdiagnosis of choroidal invasion is there, but it is very minimal. So how does it help? Because if you're planning intraarterial chemotherapy, then at least you know that there is choroidal invasion, and it may be relatively contraindicated. If you have a large choroidal invasion, either you do primary enucleation or plan for intravenous chemotherapy rather than intraarterial chemotherapy. And if you have an optic nerve extension, again, that will be known with MRI. So obviously they need to look at these two, and also perineuritic invasion, enhancement of the meningeal covering, then obviously patchy enhancement, they will be able to tell you upfront that there is perineuritic invasion where you have to adapt a different management protocol.
One more question from me. If a child presents like before 1 year, small child, bilateral RB, asymmetric RB, one is very advanced, like bad group E, other is maybe group B or C. So like we have to do enucleation in the one eye, like which is not salvageable, but the other eye will be salvageable with chemo. So what is your general protocol of primary management? And if after the enucleation of that bad group E, right eye has resolved very well with the chemo, 6 cycles. So what is your EUA protocol? Because the child is very small, till the child becomes 5 to 6 years. It is going to be a long period where many of the times parents are slightly apprehensive about repeated EUAs. So what will be your protocol for that?
Yeah, so any child, any age, in fact, younger children need more frequent EUAs than older children. But
Exactly.
having said that, after complete regression, you put them on a 3 monthly protocol. Every 3 monthly for a year, then every 6 monthly for 3 years, and then once a year, by which time the child would become cooperative in the OPD itself. Yeah, but bilateral retinoblastoma, even if it is asymmetrical, there is a good argument to start on intravenous chemotherapy so that you give a chance even for the bad eye to regress. Many times it does happen that the eye may be saved, even though vision may not be saved. So no harm if you have to give chemotherapy for the other eye, then there is no harm giving chemotherapy and trying to retain the eye. You're not harming the child because you're anyway placing the child on chemotherapy, and you can always do a secondary enucleation. Don't have to hurry with
Secondary
primary.
enucleation, you will take a call after 3 chemos or 6 chemos?
6 chemos. 6 chemos are mandatory.
The bad eye I'm like saying
Yeah.
about. 6 chemos.
Whenever you start chemotherapy, 6 chemos are mandatory because otherwise, there is a possibility of downstaging on pathology. The child may have had a histopathological high risk factor because of the 3 chemos that you gave. It could have been downstaged, and the pathologist will say no risk factors on histopathology. You'll stop chemotherapy. Then the child may recur in terms of metastasis. That was shown in the Chinese study where they abruptly stopped chemotherapy after 1, 2, or 3 cycles where the risk of metastasis was higher.
Can I ask a question, sir? Yeah.
You
So,
should answer,
like,
sir.
sometimes in cases, yeah. So there are those situations post-enucleation, say primary enucleation, where you see an laminar involvement of the optic nerve, not retrolaminar, and maybe some just, focal choroidal, not really a massive choroidal, but maybe both the things are coexisting. Now, there are kind of, different protocols, what to kind of, do in those situations. Do we give adjuvant or do we just follow up? So what do you follow?
Yeah, I would very strictly use this combined risk factor protocol where any amount of choroidal with any amount of optic nerve is considered a histopathological risk factors, because we have had a case of metastasis even with that risk factor combination. And that was actually part of the COG study. I think they have included that data in there,
Yeah.
but they still
Okay.
did not recommend
Yeah.
treatment, because
Escalating.
possibly
Okay.
ours was the only case or whatever. So even with minor choroidal invasion, which is confirmed by a central reading center, so all COG slides were read by the central reading center. There was no error at all in terms of pathology. Yet patients with these two combinations had metastasis. So I think we should.
And does it, like, if it is not choroid, but it is, say, anterior uveal involvement, ciliary body, and laminar optic nerve or a prelaminar, do you still go for?
Ciliary body, yes. Ciliary body, choroid I consider as equal. Iris, well, controversial. Iris is a soft risk factor.
One more question. A case which is on chemotherapy around 4th to 5th cycle, but the patient is rapidly developing cataract, which is like compromising the visibility. So those kind of cases, like what will be your protocol? Because we are not sure if the tumor has 100% responded. It's like kind of 80-90% regression with the 4th, 5th cycle. So what will be your protocol in those cases?
We do cataract surgery, safety enhanced cataract surgery, clear corneal incision, sparing the posterior capsule, large diameter intraocular lens, so by an expert.
The active RB behind, like you'll finish the
Absolutely.
6 cycles and then do it, or
Yeah,
how
yeah.
do we?
Finish the 6 cycles and do it before you.
And what is the duration in between the cataract surgery and the 6th
Immediately
cycle?
after 6 cycle, because you need to see what has happened after the 6 cycle. So 3 or 4 weeks after the 6 cycle, when the child comes for the next TUA, cataract surgery is performed so that you see the tumor, see what is the regression and what focal therapy you need to do. You don't wait on it unnecessarily.
So one more question. When we do a bone marrow CSF in children with clinical high risk feature on EUA, what is the protocol? Suppose one of them comes positive. So what is the right? So what is the protocol for metastatic RP?
What is the protocol for metastatic RB? If you have the facilities, if it's a hematogenous metastasis, then bone marrow positive. Well, I mean, there is a possibility of autologous bone marrow transplantation and salvage of life 10 to 15%, 20%, depends on the center and how aggressive you are with treatment. So you start them on super high dose chemotherapy, then do bone marrow transplantation and give radiation to focal areas where PET scan comes positive, and then there is a possibility of life salvage. With CNS metastasis, there's hardly any possibility. 1 or 2 children out of 100 survive, less than 5% grossly put. So if you really want to try in patients where there is CSF positivity, first thing that you need to do is a contrast enhanced high resolution MRI brain to see if there is any parenchymal involvement or only meningeal involvement. If there is meningeal involvement, then triple drug intrathecal chemotherapy with high dose chemotherapy systemically and whole brain irradiation, which leaves many of them as vegetables. So I don't think it's a good idea to be aggressive with CNS metastasis, but hematogenous metastasis, there is a chance in good centers.
What is your criteria for advising PET scan, PET CT? And if like bone marrow CSF, what is the criteria when you actually tend to repeat it? In case, even if it was negative, do you repeat it again? Or and what is the like PET CT indication?
Yeah, PET CT is done when either bone marrow or CSF are positive. You don't do it for screening. And bone marrow CSF are repeated if the child has a recurrence or on histopathology following enucleation. Even if you have done it at the baseline, the child has histopathological high risk factors. Piyush is getting bored.
Not at all, sir. They're getting to learn a lot of new things. Straight from the horse's mouth, from probably the foremost authority on retinoblastoma, if not India, Asia, or the world. Your fellows are messaging, saying it's a lovely webinar. So if there are no more questions, shall we? Thank you, everyone. Apart from Sir Ritika, thank you for being here. Dr. Seema Das, Dr. Aditi, and of course, Shubha Madam and Dr. Sumit for taking this fantastic webinar forward and doing the discussion. But most of all, thank you to Dr. Santosh Unnavar, sir, for sharing all that with the residents and every enthusiastic viewer who has tuned in, and we continue to watch repeatedly the YouTube program. And we look forward to having the second session of the Mos Pep next week. Thank you so very much, everyone, for joining in.
Thank you.
Thank you, sir. Thank you so much.